Another advantage of foot MRI is the patient doesn't have to go in the scanner, just their foot. So they can go in foot first. They like it. It's incredibly accurate. It shows almost anything you need to know. It is so underutilized. And the foot, this sounds funny, but the foot is probably the most important of the lower extremities for this reason. You can guard your hip. You change your gait a little bit with your knee. If you got a foot problem, you're in a cart. If you got a serious foot problem, you're not walking. People who've had foot problems will tell you it's one of the worst things that's ever happened to them because there's just no way around it. We are on a 31-year-old man with pain and swelling after he rolled his ankle. He's got pain laterally, limited range of motion, popping, and numbness. Well, I'll put up my sagittal water-weighted image, as I'm prone to do. So far, I'm not impressed by what I see, but this is a heavily water-weighted image. It's geared towards search. Now, I have found something. I found some high signal right there. And I might call up my T1 to see if that's a piece of bone. Maybe it's an os perineum. It is. It's an os perineum. Is that important? Yes, it is important. Because unlike os tibiale externa in the posterior tibial tendon, these give rise to tears as the peroneus longus either approaches or leaves. There's a weakening at that point, especially as it arcs around the cuboidal tunnel. So that one is more important than the os tibiale externum. You've also seen os trigonum. You've also seen os naviculare synchondrosis. All right, let's keep looking, because other than the os perineum, there's nothing else there. It looks just fine. Now, this time the patient was not plantar flexed, which is our favorite position because it straightens out the tendons, but it makes the ligaments a little harder to see. So some of you may choose to do dorsiflexion and plantar flexion. I like to do plantar flexion, and I'm used to seeing the ligaments in plantar flexion, and that allows me to just get 3 or 4 sequences at most. So let's go to the axials now. He has limited range of motion and he rolled his ankle. And we also have an os tibiale externum, another accessory ossicle. This one quite benign appearing. And wow, we have another accessory perineal calcaneal, this time not tendon, muscle, inserting on the perineal calcaneal tubercle. So far you've seen 3 accessory abnormalities in the perineus distribution and 1 accessory abductor hallucis. Wow, that's a lot. Now, I allow fluid around all the tendons, about 1 millimeter in thickness, except the anterior group. The anterior group should have no fluid. So this is abnormal. There's some peroneus brevis and longus peritendinitis, but no tear. Well, I'm going to have to take that back. I didn't read this case, but I'm reading it now. Okay, let's look at, he rolled his ankle, so we might as well look at the collaterals, right? Rolled ankle. Might say, well, ankle sprain, why do you need to do an MRI? Well, you don't. But what if they don't get better? What if they're unstable? What if they have snapping? Then you search for an OCD or an entrapped ligament or an occult tendon injury, which this patient has and was not reported. So remember the anterior talofibular ligament you saw? Remember how robust it was? It's like a sheet, but it's about 4 or 5 millimeters thick. All we see is gray tissue, and maybe this wavy, wispy little thing right there. And it's not connected to anything, is it? Even up here, that's not connected to anything. So we have torn the anterior talofibular ligament. Have we torn the calcaneofibular ligament? It's hard to tell. Maybe we need the coronal for that. Haven't. Little swollen but present. I'm going to blow it up. There it is. It's pretty straight. Granted, it's not easy to follow it all the way, but it's present. There are a few fibers of it as well, a little higher up. So it's intact, but sprained. How about the lateral peroneus longus and brevis? Well, the brevis looked funny because of this accessory muscle, but it's okay. You have to wonder why the patient has fluid around the peroneus longus and brevis. So you want to check for a retinacular injury. Got it. Right there. Too gray, too swollen, too stretched out. He's got a retinacular sprain. Want to check for a peroneus longus or brevis tear. Nobody read it, but he's got it. Follow carefully. Follow carefully. It splits. Now, that's not the usual tear that you see with the peroneus longus. Usually don't split, but this one did. So has a split tear proximal to the os peroneum, which is a site of potential weakness. How would you treat that? You'd leave it alone. It'll heal. What about dislocation of the peroneus longus and brevis? This is a static image, so it's hard to tell, but you want to at least assess the retinaculum, which is injured. You want to see if the limbus thorn is attached. It's not. There it is right there. So we're concerned, and might tell the clinician in the report, that there's a superior peroneal retinacular injury and that the patient should be checked for a subluxing peroneus longus and brevis. Going right down the checklist of the ankle sprain. The PT, that's okay. How about the deltoid? That's part of the ankle sprain search. Even though we never operate on it, that's okay. What about the talar dome? Is there an OCD? Nothing of consequence. How about an occult fracture? Nothing of consequence. Is the anterior talofibular ligament entrapped in the joint? No, it's not. In fact, it's this wispy little thing. You can hardly even see it. For if it was entrapped in the joint, you'd have to extract it. So that's also on our checklist. What about the high ankle? That's on our checklist. Anterior tib fib, intact. Therefore, all the others have to be intact because it tears as an intercalary process from anterior to posterior. So you can't tear this, you can't tear this without tearing this. So it goes anterior, interosseous, posterior. And that looks just fine. There's the posterior. There's the anterior up higher. So no high ankle component. So the conclusion would read, mostly single part, high ankle sprain with rupture of the anterior talofibular ligament, but without entrapment, period. Next paragraph. Inflammatory tissue in the prefibular gutter is at potential future risk for the production of a meniscoid lesion, which is basically a pseudotumor in this space that keeps the ankle ligaments from healing. Number next. Superior perineal retinaculum and limbus thorn injury, placing the patient at risk for perineus subluxation. Number next. Mild peritendinitis of the perineus longus and brevis due to retinacular injury and a very delicate small perineus longus split tear. Number next. No occult fracture or traumatic OCD. In the body of the report would go the rest of the findings like the os tibialis externum. The question is, what do you do when you go proximal to the malleolus? What do you say about the fat character of the perineus longus? Generally, it likes to eat a lot. It generally is a very fat tendon. So it doesn't bother me at all as long as it's completely signal normal. And you've got a pretty good reason for it to be a little chubby anyway. You know, you've got a lot of tissue in the area, you know, that's kind of pushing things together. So I'm not at all bothered by it. 11-year-old evaluate for synovitis. This will be a quick one. Let's just see what that looks like. We saw RSD, remember? Peripheral edema. We have peripheral subcortical edema again, and also spotty edema, but this time we've got synovitis. That's pannus. That's not simple fluid on this T2 weighted image. That's all pannus in the stem ligament bursa or frondiform ligament bursa arising from the subtalar space. This is all reactive edema throughout the mid-tarsal region. Let's take a look at it coronally real quickly just to get our eye comfortable with it. It's an oligo or pauciarticular arthritis rheumatoid negative, consistent with JIA. I think the sagittal is much more instructive. You can see why I like the sagittal so much. Very comfortable. And then in an arthritis case, you want to assess the severity of pannus, the character of the erosions, the location of the erosions, whether there's tenosynovitis, tendon injury or rupture. There is some tenosynovitis, but no tendon rupture, and whether there are rheumatoid nodules. There are not. So this is JIA. Compare that with your RSD or complex regional pain syndrome type 1 case. That's a beauty. How important is the contrast? Very unimportant. First of all, do you really want to give contrast to an 11-year-old whose kidneys are still maturing? We know that neonates don't do as good a job at excreting gadolinium as adults do. So it goes, you know, it's natural to think that a 13-year-old isn't going to excrete as well as a 21-year-old. So unless, back to what we discussed yesterday, unless you really have a reason to give it, don't give it. I mean, what are you going to do? You're going to say, well, it's a little brighter this time or a little less bright, you know, to monitor it. The risk doesn't justify the means. You can look at the amount of fluid and the amount of pannus and the number of erosions and say if they're stable or progressing without giving contrast. Personally, I think it's a bad idea. Now, if you have a situation where you're unsure whether there's synovitis and you're not experienced, maybe. But even then, I take it to your experienced colleague and say, is this synovitis, before I gave gadolinium. I really prefer not to give gadolinium to children. Brain tumor? Sure. You have to weigh, judgment. Medicine is judgment. I debated whether to show this to you because it's a kind of a complex case in terms of the findings. I'm going to put up one sagittal, one axial, and one coronal. I'm going to pick them randomly right now so I can give you as much information as possible without rushing too fast. A very swollen foot. Left ankle pain, no trauma. So we're not going to be honing in on the anterior talofibular ligament, which is normal, nor are we honing in on the intact, well-seen calcaneofibular ligament. 2, 3, 4, 1. They're all present. They're not necessarily normal, but they're present. For instance, there's severe hypertrophic tendinopathy and interstitial chronic tear of the supramalleolar posterior tibial tendon. There's peritendinitis. There's some peritendinitis around the lateral group, too. There's quite a bit of fluid. The fluid is in the subtalar space. There are erosions in the subtalar space. There is fluid tracking proximally. And there's fluid tracking distally, too, producing a pseudomass at Henry's master knot, where the flexor hallucis and digitorum meet and become friends. They're kissing. Okay, I'll give you all that. I'll give you the ankle effusion. The subtalar space looks terrible. Wow. And you know why it looks terrible? It's dysplastic. There's the talocalcaneal IOL. And then it just dives into some awful-looking tissue. That's the cervical ligament right there. This is all inflammatory tissue, but not primary synovitis. The lateral retinaculum is very irregular. And with all this inflammation, it is likely that this patient has sinus tarsi syndrome from dysplasia. Why do they have dysplasia? And there's your nasty, chronically torn posterior tibial tendon. There are probably 20 findings in this case. Even the Achilles isn't normal, right? Achilles is too fat. Look at it sagittally. It's a little tendinotic. See, it gets a little fat up there. That shouldn't happen. Shouldn't go from thin to fat. Plantar fascia is a little swollen. Okay, so what? So what's the main problem that led to all of these crazy findings? There it is, right there. Fibrocartilaginous calcaneonavicular coalition. And having that for 58 years, that could do it. And it did. A 17-year-old female, pain, since feeling a pop while running track 2 weeks ago. So she felt a pop. Could be a tendon rupture. Didn't describe an inversion or an eversion, so you're not thinking collaterals, but you're going to check those anyway. Going to check all the ligaments. What's the main ligaments you're going to check? The anterior talofibular ligament, but she didn't invert. What's the second main ligament you're going to check? I don't care about the other ligaments for now. Ask yourself, what is the second main ligament you're going to check? The Lisfranc ligament. Every single time. Does the Lisfranc ligament retract? It does not retract because it's in this tiny, teeny little space. So when it tears, it might do this. Better check it. That may not be the diagnosis, but then again, it may be. Going to have to decide. Let's blow it up. I like to put up the sagittals because when I have any concern about the midfoot, I want to see if the tarso-metatarsal bones are infracted, fractured, or have macro fractures. So I start trolling around, and I do see some midfoot edema. And it's not inconsequential. And it tends to be centered in this patient about the first and the second. So I'm worried. I'm very worried. And you should be too. And that's usually how I'll start a case like this. Now, I knew she didn't invert, right? That was important. So let's look at the coronal. I'm not sure that's going to add a tremendous amount. All right, so now we got to decide. It's decision time. Is she going to get an operation? Who decides that? You do. Now, sometimes the clinician will just take charge and say, I don't care what you say. I know this is a Lisfranc. And I just had that happen to a celebrity patient. I got called. Somebody read it as normal. I got a call from this celebrity orthopedic surgeon, who's a great guy, by the way. He said, it can't be. It can't be. He goes, this guy is, an all-state football player, and he's going to Arizona State, and he'll probably play in the NFL. I got to be sure that it's intact. Somebody called it sprained or not injured. Well, it wasn't intact. It was transected. And so the next day he was in the OR, and he's actually in spring camp now getting ready for Arizona State. So this happens all the time. That's not one. That's one of many. There's an end. There's an end. There's the butter knife that cut it. That's transected. Is the base of the second and the cuneiform wide? You bet it is. It's the isolated form of Lisfranc ligament rupture. Now, don't confuse the intercuneiform ligaments with the Lisfranc ligament. Now, the Lisfranc has three components. A dorsal component, which doesn't mean much at all. We don't care about it, but it happens to be torn. Can't find it. The middle interosseous component, that's the most important. That's torn. Then the plantar components, we have a C1M2, that's torn. And we may sometimes have a C1M3. Well, if we did, we don't see it anymore. So that may be the last vestige of it right there. I don't know. But I don't see a C1M3 ligament. So at the very least, I would say isolated form of Lisfranc ligament injury / rupture. I'd use the rupture word, or I'd use the tear word, with involvement of the plantar Lisfranc complex, including at least C1 cuneiform to M2 base of second ligament, and possibly C1M3. Then I'd also go out there and talk about the fractures and the microtrabecular fractures that are present. And that would probably go in the body of the report, and in the conclusion I'd just say something like innumerable chip and microtrabecular fractures consistent with a midfoot sprain and Lisfranc rupture. So one sentence. Now you can see the Lisfranc ligament in the short axis view if you're used to it. So let's go to the Lisfranc ligament. There's the tear. You can actually see it right there. It's gray and it's black. But it's not easy to make the diagnosis of a tear in the short axis. You know, it looks contiguous, and a lot of people will underread it for that very reason. Because you're looking for this tiny little slit, and you just can't resolve it or pick it up in the short axis view. Let's check out the sagittal one more time. The sagittal T1, look at all these fractures. Let's blow them up a little bit. And sometimes there'll be macrofractures. Now, the classic fracture is at the base of the Roman column. Like to break down the foot into 3 columns. You've got column number 1, column number 2, and then column number 3 out here for the 4th and 5th. So 1, 2, and 3. Column number 2, the second, is recessed. So if you look at it, look how the second is recessed relative to the third and the first. Let me take my markers off. Recessed. Right there. So that's why fractures here in a midfoot torsion injury occur. Now, how do you get this injury? Foot's planted on the ground, and then you twist. Or the foot's planted on the ground, and somebody falls on your heel and drives your heel down when you're in the toe, not the toe pointed position, but when you're in the dorsiflex position on the ball of the foot. So you're like this, and then somebody slams on the back of your heel and slams it down. So that's the other way, or a torque. That's the typical mechanism for a Lisfranc injury. Let's do the next one unless you have a question. Very important case. Can't miss that. 21-year-old male with left anterior medial foot pain since a football injury 7 days ago. We've got a marker in the area of pain. Let's go immediately to the sagittal. I'll speed up now a little bit. This is a PD stir. There is some swelling in the midfoot, but not as much as in the prior case. He's a big boy. Got a big foot. Let's check out the T1. There's the marker right over the first TMT. Let's keep going, shall we? Let's go to the short axis views. We have a pretty exquisite, heavily fat-suppressed water-weighted image. Lots of swelling around the first. There's your tibialis anterior tendon inserting on the cuneiform. It's okay, even though there's lots of swelling in the neighborhood, that has to be a worry with the pattern of swelling. Here's your extensor digitorum, your extensor hallucis going to the great toe. And there are your extensor digitorum structures fanning out and going everywhere. So far, we don't have a good answer. Were it not for this widening. Don't like that. Don't like that widening right there. There's a little bit of skeletal abnormality, less than I would have expected. Okay, let's get out our Lisfranc views. And what's a Lisfranc view anyway? It's a view where your axial is not this. It's this. Let's see if they did Lisfranc views. They did. And the Lisfranc ligament is done. Gone. Here it is right here. He's also torn the medial collateral ligament of the first tarsometatarsal junction. Let's keep going, shall we? This looks like a pretty serious injury. So the main ligament is gone. Fortunately, we don't have splaying, so-called divergence of these columns from these columns. That's the divergent type. And fortunately, they don't all migrate to one side, the convergent type. But let's check out our plantar ligaments. I'm not sure what even to call them. I would call them ligament soup. Can we even spot a linear, smooth, black anything? No. So the plantar ligaments are gone. Do I care whether it's C1M2 or C1M3 or both? At this point, no, I don't care. You're getting an operation. So I'm going to say plantar ligament complex torn, probably C1M2. C1M3 may be there, right there. Don't care. All right, how about the dorsal one? I don't care, but let's see if we can spot it. Do a little train spotting. And that one is torn. This is down in the interosseous area, and we'll go up. There it is. There's the dorsal ligament. So the dorsal ligament's torn, the interosseous ligament is torn, and the plantar ligaments are torn. All three layers of the Lisfranc are torn. I might have a few words to say about that. So ligaments have origins and insertions. They can avulse with bone or without bone. But the Lisfranc ligament, it's a mid-substance tear almost every time. They can fray, ligamentum teres. They can peel, the UCL. There are often multiple layers, like the MCL, so you can have a superficial, middle, and a deep component. It usually tears from the outside in. There are special ligamentous abnormalities, like the entrapped Stenner lesion of the thumb, or the secund ligamentous injury that tells you you have a lateral capsular tear, or the reverse secund on the medial side. You can grade injuries by part, by how many ligaments are involved. Single part, double part, triple part for the ankle. You can have them high or low in the ankle. You can tear the capsule, which is actually a ligament, or the ligament is a capsular condensation. Other qualifiers. Certain ligamentous injuries in concert give you various types of instability, like AMRI, anteromedial recurrent instability, or PLRI, posterolateral recurrent instability. You can figure out what's going to happen by knowing the mechanism, just like we discussed in the Lisfranc ligament. Or is it varus or valgus? Or was the foot planted? Or was the foot extended in the air? Is the ligament entrapped or enfolded, as occurs in ankle injuries? And does the patient have pre-existing micro or macro instabilities? Probably nowhere is it more straightforward than in the elbow. The elbow is supported by the skeleton and by the various grooves that fit together, and it's supported by dynamic structures like the common extensor and flexor, and by the static capsule and ligaments. These include the three bundles of the MCL, anterior, transverse, and posterior, and the two bundles of the LCL, the proper lateral collateral ligament, and the LUCL, the lateral ulnar collateral ligament. So here's just an example. Here's a patient with Overload of the elbow, there's the ulnar collateral ligament. What's on top of it? The aponeurotic layer of the flexor digitorum superficialis, layer number 1. So he's got a layer number 1 sprain, layer number 2, it's okay. So a very subtle example of ligamentous overload where the underbelly of a muscle forms the outer layer of a ligament. That's kind of weird. And here we have the muscle is layer 1, it's aponeurosis, the ligament in green, and the joint capsule is the 3rd layer. Let's skip over this, and you've seen the 3-layered knee ligaments. Layer 1, crus, layer 2, tibial collateral ligament, and layer 3, the meniscofemoral and tibial attachments, along with the POL and the posteromedial capsule, the posterooblique ligament of the knee. And I showed you already some pretty horrific ligamentous injuries on the lateral side, so there's no need to revisit this. But I think revisiting this is helpful because some of you are asking me about the ligamentous anatomy of the shoulder, which is a little challenging. So you've got 4 major ligaments. You've got the coracohumeral ligament, the forgotten ligament. It forms the anterior boundary of the rotator interval, so it's going to be over here. It's the front of the interval triangle. It also makes up most of the transverse ligament and keeps the biceps in place. Traveling with the biceps and going out and then over and then under the biceps is the SGHL. Then you've got the linear or oblique, can do whatever it wants, or perforated MGHL traveling with the subscapularis. And then all the way at the bottom you've got the anterior band, the posterior band, and the axillary band of the IGHL. So these are important static stabilizers along with the musculature. In the thumb, you've got a very important ligament, the ulnar collateral ligament, which sits underneath an aponeurosis. It can thicken, it can fray, it can avulse, it can tear and fold backwards and get stuck underneath the aponeurosis, a subject we'll discuss a little bit later. The ligamentous anatomy of the finger, rather complex. You've got a collateral ligament, and then you've got an oblique curved accessory collateral ligament, which fuses with this very thin ligament, which you can't see except proximally, called the check rein, which fuses with the palmar plate or plantar plate, and then on top of that is the deep transverse intermetacarpal ligament. And these have antagonistic functions. When you flex, one stretches, and when you stretch, the other one flexes. And then we've already talked a little bit about the ligamentum teres. 50-year-old female with dorsal forefoot pain after an injury. Let's see if we have anything water-weighted, just to get a pattern of injury. This is more of a forefoot study, but most of the swelling seems to be over here, doesn't it? So this is sort of how I would get my bearings in a case like this, where there's not a lot of history. I go to the water-weighted image and see where the greatest intensity of swelling is. And it all seems to be centered here, not in the shafts and not in the toes. And as I'm scrolling the toes, you can actually see the plantar plate right there. That's the plate. Resolution isn't very high. Let's go to our long axis view. Maybe take a short axis view. Well, on the water-weighted image, the Lisfranc ligament looks pretty good. Still looks pretty good. Doesn't look so good there. There's a little fracture right next to it. Let's blow that up a little more. Could it be that I would show you 3 of them in a row? Would I be that skullduggerous? Yes, I would. Now, it's a ligament, right? Why is it gray? It's not very wide, so if you call this a partial thickness tear / clinical Lisfranc sprain, I wouldn't argue with you at all. But you better tap into the fact that the Lisfranc ligament is not normal. Let's go down and check the plantar ligaments. Well, that's a ligament. That's a ligament. That ligament should look like that ligament. Plantar ligaments are not normal in this patient. They're swollen. So this is not an inconsequential injury. There's a dorsal ligament. That one's present on the left. So a third Lisfranc ligament injury, this one would be treated non-surgically unless it was a performance athlete, usually immobilization. But it really depends on the degree of instability. This one was treated conservatively. The last 2 were operated on. All right, let's move on to the next one. 48-year-old with left foot pain and swelling. You're not kidding. Okay, there's a point here. I mean, what do you do with a case like this? Close the case. Okay, so I put up all 3 of my sagittals. Now, they gave gadolinium to this diabetic with renal disease. Did we really need to? Did we really need to show that there was going to be enhancement of all these bones? Not really. So the question you have to ask yourself is, are the bones fragmented or are they destroyed? And then the next question you have to ask yourself is, does it really matter? Okay, I would say on the T2, some of them are fragmented. They're just shards of bone, and some of them are just wiped out. Like I can't even see the bone. So sure, the contrast made it a little easier, but all these bones that are wiped out, osteo. But that doesn't matter because the patient has this gigantic abscess and another one there. Their leg has to come off. So, you know, it's kind of risky to give gadolinium and somebody with a GFR of 30 who's a diabetic when you already know you got to do an amputation. What is that going to give you? You're much better off saying mixture of Charcot foot with innumerable bones that are infected with a giant abscess that is dissected into the heel. I mean, you can see that cavity on T2. I mean, what else would that cavity be? A seroma? A lymphocele? That's silly. In the middle of the bones, it could only be an abscess. Now, granted, it has the perfect rim enhancement, nice and thin and homogeneous of an abscess. So this is a case management scenario where you have the approach you need. You don't have to go overboard and do innumerable sequences and start giving gadolinium to this patient. Look at that abscess. The thing's huge. And it's everywhere. Let's look at another one. So that's a what to do case as opposed to the findings. 10 weeks of ulceration in the first toe in an 80-year-old that keeps getting deeper and deeper. He's got neuropathy, and type 2 diabetes mellitus. Now, if you're sadistic or you have no environmental conscience, you can do an indium 111 study. Or if you trained as a nuclear medicine doctor and you don't do radiology, you might do a gallium study. And it would come out like this. Enhancement that may represent infection, but can also be seen in other inflammatory disorders, can't rule out, and then you get a long list. Or you could simply just look at the T1 weighted image. Let's do that. This is the detector image, and this is the specifier image. And we said you can get edema from osteomyelitis on the water-weighted image, but it has to be on the T1. Otherwise, it's reactive. Otherwise, it's periostitis. Otherwise, it's non-invasive, non-penetrating disease. So let's see what he's got. Pretty simple. Let's check out the great toe. I'm not going to make anything fancy about it. Let's go to the coronal. Oh, heck yeah. There's the ulcer. There's some decent-looking bone, but not a lot. That bone, that looks terrible. It's starting to evaporate right there. The bone is starting to evaporate. Now, we're not done yet, because they got to know, where do I cut? You got to amputate that. So is there involvement of the phalanx proximal to it? Now, granted, the patient moved all over the place, and I apologize for that. I think we have one that's a little less motion affected. Oh, look at that toe. The vanishing toe. Hyper intense on the water-weighted image. But on the other side of the joint, nothing. So you can spare the other side of the joint. You don't have to take the phalanx, only the tuft. Yes, there is cellulitis. Yes, there is an ulcer. Yes, there is a metatarsal valgus deformity with arthritis and an erosion. All those things are true. Yes, there is diabetic amyotrophy with massive fatty infiltration of the muscles. But you've answered the question really quickly, actually. All you needed was the sagittal and the axial T1 to answer the question. Maybe one water-weighted image. Okay, let's do another one. Trauma. Now with mass on the bottom of the foot in a 53-year-old man for 2.5 months, and it's growing and it hurts. Let's go right back to our sagittals, the old lateral radiograph. A spindle-shaped lesion. He had trauma. It's a hematoma. Well, where's the methemoglobin staining? Why is it 2.5 months? If it's an ossified hematoma, why isn't it dark? Who ever heard of a hematoma in the plantar fascia and aponeurosis? It could happen, I guess. But when you have these linear streaks, when you have something that looks like this, almost like a corduroy effect, that tells you you're dealing with something fibrous or the family of desmoids. Now, this is considered a low-grade, non-aggressive type of fibrous lesion. That's why it's called non-aggressive fibromatosis. That's why we don't use the term desmoid, although it's a benign desmoid. So is Dupuytren's contracture of the hand. About 25 to 30% of them, of these patients, will have Dupuytren's contracture of the hand. Men more common than women in the foot. Women more common than men in the hand. People with this entity will get Dupuytren's contracture, or they're at higher risk for it. Now, even though it's a fibrous lesion, it does on heavily water-weighted fat-suppressed images, it does get a little bit brighter. Let's see if we have a T2. It'll be pretty dark on the T2. And it is. Now, the less dark it is, the more aggressive it is. In other words, the more invasive it is. What's the treatment? Most of the time, leave it alone. Because when they come back worse. So unless it's really invading the deep tissues, you're better off padding the shoe and leaving it there. They'll never metastasize. You start manipulating them, then you get into problems. Deformity, recurrence, and more aggressive behavior. So even though I don't advocate operating on these, the really big ones, they're sometimes forced to, so you want to tell them if you are in the deeper space, this one is. You want to give them a length, we would. You want to give them a width, we would. You want to tell them what chord it's in the central chord. You want to tell them where it is relative to the metatarsals, so you give them an anatomic landmark. These are not easy to excise. But this family of fibrous lesions, both the desmoid and this benign desmoid, which is really non-aggressive fibromatosis, have that linear, somewhat squiggly parallel pattern like this. That's kind of the tip-off to the diagnosis. These occur in the same place almost every time, right at the base of the metatarsals, in the central cord of the plantar fascia. This is a big one, although we've seen them a heck of a lot bigger. Look at that kind of corduroy look. Let me blow it up for you. That parallel kind of spaghetti look. That's very typical of this entity and related entities. Now, there are other fibrous lesions you can get in the foot, but they're much less common. In an adult male, this is going to be 80% of them. You can get fibromas. In children, you can get aggressive fibromatosis or childhood fibrosarcoma. That's a very bad disease. That's much different than this. You can also get in juveniles calcified aponeurotic juvenile fibroma. They're calcified. These never calcify. So if you see calcification on plain film, you got to think about another potential diagnosis. Some related diagnoses that don't occur in the foot: elastofibroma dorsi, women, axilla, scapula. But a very similar kind of pattern internally, because they are fibrous lesions. And then the classic aggressive desmoid, they look like this, but they have more linearity inside, and then they have more tentacles spreading into the surrounding soft tissues. Very, very difficult to cure. Would steroid injection be of any use? Yes. It would be very helpful to the person doing the injection, because they might get paid for doing the injection. But there would be no clinical benefit whatsoever. But it might pay for some tuition.